You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. In this episode of The Dish on Health IT, we're joined by Angel Ballew, Senior Vice President of Pharmacy Clinical Operations at Centene Corporation. Host Tony Schueth, CEO of Point of Care Partners, and co-hosts Seth Joseph, Managing Director of Summit Health Advisors, and Jason Reed, Senior Consultant at Point of Care Partners, talk with Angel about what it takes to scale pharmacist-delivered clinical services. They explore the role pharmacists can play in closing care gaps, the reimbursement and operational barriers to sustainable programs, how success should be measured, and the importance of data interoperability and the collaboration between health plans and pharmacies. We hope you find this episode enlightening. If you have suggestions for future episodes, visit the podcast page at POCP.com under the Insights section and share your ideas with us by completing a form.
All right, let's get this party started. Welcome to The Dish on Health IT. I'm Tony Schueth, CEO of Point of Care Partners, and your host for today's episode. On this show, we explore the policy, technology, and business issues shaping the future of healthcare. And today we're tackling a topic that's gaining momentum across the industry: how to scale pharmacist-delivered clinical services. The inspiration for today's conversation came from a recent NCPDP Foundation-funded white paper, a business model framework to scale pharmacy-delivered clinical services, to which Point of Care Partners was proud to contribute. The research highlighted an important reality. We already have plenty of evidence across a range of studies that when pharmacists deliver clinical services, they improve patient outcomes. The challenge is figuring out how to make those services operationally and financially sustainable at scale. Rather than simply discussing the findings of the paper, we wanted to bring in someone who's living and working to solve these challenges every day. Our guest is Angel Ballew, Head of Pharmacy and Clinical Programs and Services at Centene. Angel has a unique perspective on what it takes to deliver pharmacy services across one of the nation's largest and most diverse managed care organizations, serving millions of members in communities with very different needs. I'm looking forward to hearing how Centene thinks about expanding pharmacists' role, closing care gaps, measuring success, and what still has to change to make these services scalable. Joining me today are two of my colleagues who helped with the research and development of the white paper, Seth Joseph and Jason Reed. Throughout today's conversation, they'll add perspective and from dozens of stakeholder interviews and industry research that informed the paper, helping us compare what we heard across the market with Angel's real-world experience. So let's get everyone introduced. Let's start with our co-hosts. Seth, why don't you kick us off?
Thanks, Tony. I'm Seth Joseph, Managing Director of Summit Health Advisors. We are a boutique consultancy, and we were proud to work with Point of Care Partners on the grant award from NCPDP Foundation to research this topic: how do we scale pharmacist-delivered clinical services nationwide? Great to be here. Jason?
Jason Reed. Worked with Tony and Seth on the white paper. I'm a pharmacist with about 20 years experience with standards and have worked with Point of Care Partners on this project.
Great. Please introduce yourself, Angel, and tell us about your current role. We always find it interesting how many people got to their current roles through the design of or happy accidents.
Sure. Well, thanks for having me, Tony. Pleasure to be with you all today. I'm Angel Ballew, and I lead Pharmacy Clinical Programs and Services here at Centene. I'm a pharmacist by training and board certified in psychiatric pharmacy. And I also have an MBA in health administration. Really, no matter what role I've been in, I think the common thread when I think about my career journey is really always been about helping people get the best possible outcomes from their medication. And so to your point, my path into this role was really much more evolution than design. My very first job was in retail pharmacy. And so I've been in pharmacy since I was allowed to have a job out there in the wild. And I started pharmacy school really picturing that traditional pharmacy career. Throughout my time in pharmacy school, I really discovered how much I enjoyed direct patient care, specifically in psychiatric pharmacy. And I was also really intrigued when I was working in those situations around the business decisions that were being made behind the scenes. So following residency, I had positions in hospital pharmacy, later in academia, where I managed pharmacy services and outpatient clinics, and certainly ran into some of the challenges that we are going to talk about today. And all of those experiences, I think, have really brought me to this part of my career where I'm trying to solve these problems at a much broader scale. So I'm excited to talk with you all today about those. And to your point, definitely happy accidents that have led me into managed care.
Well, thanks for that, and we're glad you're here. Um, and a not well-known part of my career is that I actually, when I went to graduate school, I worked as a pharmacy tech in a hospital. So I had a little bit of that, a pharmacy tech supporting, pharmacists in a hospital. So I have that in my background as well. Let's move forward. So Centene serves a fair number of vulnerable and rural populations. Angel, what's your perspective on the role pharmacists can play to help close care gaps where provider access is limited?
Well, you're certainly right, Tony. At Centene, we serve many members who face barriers to care, including about 3.5 million people living in rural communities. So really our approach to access goes beyond geography. We need to focus on challenges like transportation, housing, food insecurity, many of those social determinants of health that you probably have heard outlined, maybe in some previous discussions you've been privy to. We certainly understand, particularly in today's environment, that when provider access is constrained, pharmacists can be one of the most accessible healthcare professionals in the community. Patients may see them more often even than their physicians or some of their other, specialty providers. And I think that this really shows that their role can go far beyond just dispensing medications. These frequent touch points that patients have with pharmacists really create opportunities to reinforce adherence, identify medication-related concerns, provide immunizations, which we saw be wildly successful during the COVID-19 pandemic. And then I think, more recently, a lot of the evolution in performing test to treat services, et cetera. So, here at Centene, we are working with pharmacists and pharmacies in a number of ways, medication synchronization efforts, that refill support, adherence programs, et cetera. And we're even doing some things along the lines of blood pressure screening. So many of these programs have been part of our strategy for years, but I would say we've had to continue to iterate on them for many of the reasons that the white paper talks about. How do we scale? How do we bring pharmacists to the table in the right way that allows them to want to participate, but also allows us to get the value out of the programs that we're needing and desiring from those investments. I would also just add that another exciting area is pharmacist provider status. And so really, as states continue to expand what they're allowing pharmacists to do, I think there's really an opportunity for them to deliver even more clinical services at scale, especially in these communities where provider access is limited. And, that's very important to us here at Centene with our vulnerable population. We certainly actively support these efforts, and I would be remiss if I didn't, call out the great work of our internal pharmacy advocacy committee that's led by a colleague of mine here, Miraza Patel, which is helping kind of advance those policies so that we can recognize pharmacists as really integral members of our healthcare team.
Seth, that's very helpful. Thanks, Angel, for going through that. But Seth, Angel talks about a variety of different services that Centene provides. What are some others that we heard about when we were doing our research?
Yeah, well, let me acknowledge and applaud Centene's work and leadership in this area. I think it's fantastic, and certainly look forward to hearing more. Um, Gosh, I'm trying to think of some of the types of services we heard commonly provided. And when I say commonly, I don't mean necessarily broadly that are publicly really well aware, but which are being piloted and or there for which there are demonstration projects or even beyond mature programs being executed. Among those, they include gaps in care, counseling. Test and treat, I know, is a big area of focus right now, both across many programs across states, but also federally. I believe there's some discussion in Congress about test and treat. Um, and medication counseling, certainly medication therapy management. And Jason, perhaps you might be able to chime in with a few of the others, but I think we identified there were five or six that we heard that kind of rose to the top. And I don't have all my notes in front of me, so I named a few. And Jason, if there are any I missed, please chime in.
Yeah, so I think that, like the preventative care services like immunizations and screenings for those type of things is certainly a big one. One of the things that kind of rose up in the research that we did was, pharmacy benefit versus medical benefit. Immunizations can actually be billed through the pharmacy benefit. So that was one of the reasons that that's a leader. But I think, you hit on one of the big ones that's emerging. I also work on the Sequoia group, and they went through and created some various different use cases for this. Test to treat is probably the one that's got a lot of buzz, along with like chronic disease management, where patients will have diabetes, hypertension, those kind of things, and pharmacists can fill gaps, in between visits to the physician on those disease states for sure.
Jason, it's interesting that you bring up pharmacy versus medical benefit. So pilot programs show strong outcomes, but scaling seems to stall on these reimbursement issues. What needs to change? Angel, let's start with you.
Yeah, and I think the white paper pointed this out pretty well. Certainly, we run into that situation of, is there enough volume for a pharmacy, particularly to be able to participate versus is there enough lift or outcomes we're going to see as a health plan from the participation of pharmacies that are participating. And one of the big challenges, to your point, was really around reimbursement and credentialing. And so what I would say is we've, been a part of some of these struggles. And certainly I would say here at Centene, some of the things that we're working on are what are those credentialing opportunities and how do we make sure we make that information easier for our pharmacy partners? Certainly, this doesn't give us, I think, to what the ideal state is, which is one standard credentialing model that can be used by all. But given our reach within Centene across our close to 27 million lives, I think this does bring some level of standardization or potential model to adopt from. And so we've done a lot around advocacy within our individual states to ensure that we have pharmacy at the table with our credentialing department. Certainly there was some internal education that needed to happen there, right? Because I don't think this is the profession that most are thinking about when they're thinking about credentialing. And so we've done a lot of that internal work, but then also taking that out from an advocacy perspective to make sure we have some really clear outlined steps in how pharmacies can participate in these services.
Seth, with our project, I recall that some of the folks that we talked to were using the pharmacy benefit, were reimbursing through the pharmacy benefit, others through the medical benefit. What needs to change? What's your perspective on that?
So we think, and our research pointed pretty strongly to the fact that it needs to be health plans and pharmacies who together lead. That's not to the point of excluding pharmacy benefit managers. Pharmacy benefit managers play an incredibly important role. They have relationships, they have networks, they have technology, they have established processes. The challenge that we identified is that within a PBM, if there's a really innovative pharmacy clinical services champion who wants to pilot new programs, the PBM has no agency on its own. That pharmacy champion within the PBM needs to go out and sell a client. Maybe that's an employer client, maybe that's a health plan client in a specific geography. And then they've got to go out and work with the pharmacies as well to bring them together. But that PBM is maybe selling one client or trying to bring one client to the table. And that's just really, really hard work. Health plans are going to, by their nature, oftentimes have substantially more agency. By agency, I mean the ability to influence and to take action sort of their own volition. And I don't mean to paint health plans as a monolith. And Angel, I'd love to hear your thoughts about this. Certainly, health plans have different lines of business across different geographies, so there's complexity to encounter there. But I think they can tend to have, and depending on the line of business, more agency to create self-started or self-initiated programs and start to pilot those programs and perhaps roll them out a bit more quickly. So that's what we heard. That's what we synthesized from our research. Angel, I'd love to hear your thoughts and tell me if you agree or if you think I'm off base or missing something.
No, I don't disagree. In fact, when I think about the work we've been doing here at Centene, we've been doing it directly with the pharmacy community through some other industry partners, not necessarily directly with our PBM, although I 100% agree with you that we have a great relationship with our PBM and do a lot of fantastic work with them. I would say in some of this, it's been call it grassroots efforts state by state, given some of those very specific state regulations around kind of pharmacist scope of practice. But then I would also say we have over the last 2 years done a really great job, in my opinion, of bringing a national scalable product to our pharmacy partners. And in that, it is very consistent as it relates to what measures we are trying to support. This happens to be quality measurement focused, although we're using this as an infrastructure to bring other services or opportunities to the broader pharmacy market. So we think that there's a good position there. But we've scaled this national program, and I think what's really important is we have close to 73% participation. And that's inclusive of pharmacies who are participating nationwide. So kind of against that backdrop of, what do we call it, 65,000 or so pharmacies out there that kind of are available to contract with. I think what's probably most important about that is if I tease out our large chains, right? And I think in some ways, this conversation is really about how do we also get involvement from those individual pharmacies in those rural areas and communities. Is really, I think what's really great is we've grown that number by over 10,000 pharmacies over the last couple of years, and we're now have close to 30,000 pharmacies that are contracted to participate in this program. And what we're seeing is year-over-year adoption. And I don't recall if it was mentioned in the white paper, but I think I would say some of this is, oh, what was that? What was the movie with Kevin Costner? Like, if you build it, they will come, right? And I think
Field of Dreams.
Field of Dreams. Thank you, guys. It's one of those things where we built it, and I think at first it's like, oh, well, maybe pharmacists don't want to participate. And I almost think there's a little bit of a stability and credibility aspect that I think the 2 years of not wiping the slate clean with something completely new, but taking in feedback and continuing to iterate, that also gives, some of our pharmacy partners a little more confidence that the work is there to lean into. And so we certainly had really, really early adopters in the program who hit the ground running, had the right infrastructure, maybe already had the right things in place to say yes and show us that it's doable. And then I think we've had to also kind of get in there and have really direct conversations, including getting behind the pharmacy counter. I think we did 13 visits this past month just in Detroit with pharmacies on, okay, how do we see this in your workflow? how can you participate? And so, it's really sometimes doing that like one by one, but then I think that consistency really helps bear the fruit of that labor.
So our white paper research found that the primary barrier to scaling pharmacy clinical services was something known as the cold start or chicken and egg problem. Pharmacies wait for sufficient patient volume from health plans, while health plans want sufficient pharmacy coverage first to prove outcomes. The result is that each side waits for the other. In the meantime, real tactical barriers like different credentialing requirements, enrollment processes, reimbursement and reporting requirements stall the market. We suggest regional initiatives, pharmacy health alliances for reimbursable medical services, or PHARMs, where health plans and pharmacies come together to solve these issues in a regional area to solve cold start problems. We've gotten positive feedback, but we recognize things work differently when you've got a P&L to manage. What's your reaction to the PHARMs concept, Angel?
Yeah, well, first I'd like to say what I like about the farms concept. So it certainly starts with the right problem, right? I don't think that we lack clinical evidence on, how pharmacists can support. I think also we've got fairly good alignment on their ability to help close some of the gaps where maybe we're short on providers. But we do lack alignment on the business model. I think the one area within that concept that I would encourage maybe some additional consideration, though, is really kind of the complexity of the health plan operations across different lines of business. And I do think the paper gave some nod to these complexities. Certainly, health plans have different priorities by line of business, and Centene's no exception. Us aligning on 100% on, all measures that maybe are important for all lines of business. While we can get there, I think there's some uniqueness right in the industry that does require us to focus, whether it's a patient population that we need to focus on where we see a need, or around quality measures that are specific to a line of business. And so I'm not sure that we're going to come to 100% consensus, but I also think that there's ways to march towards that. So again, I think, some of these differences are driven, not only by the, quality measures that I mentioned, also our member needs. My health plan might have concerns in one area within a similar population than another health plan, and we want to make sure that we're addressing our specific member needs holistically in these types of programs. And then certainly I think there's some regulations and benefit design. We certainly operate in numerous, Medicaid environments, all with some different regulations. And so I'm not sure if a single regional model will kind of naturally align on a single regional model around every health plan for same services, but I do think there's places that we can align that brings enough same that some of those nuances can, be worked out on the back end.
I don't think that we were advocating a cookie cutter model, were we, Seth? Or what's your take on what Angel's comments?
No, I think that's fair. And what's the I've been using the expression, it's one thing to know something, it's another to experience it and go through it. And so, Angel, I think we have a recognition that a health plan is not a monolith. It can have many different lines of business within a given geography. And so, to your point, we may recognize that and acknowledge it in the white paper. I'm sure it feels very different when you are working with those challenge or different priorities and operational tensions, et cetera, and trying to meet different member needs across different lines of business, not to mention across different health plans. And so one of the things we were recommending with farms, or the reason to start with a regional approach, is the recognition that we didn't think problems like service prioritization or reimbursement and contracting standardization or credentialing and enrollment sort of infrastructure, quality measures you talked about, could be reasonably solved at a national level. There are the variations are too broad. Our thought about working at a more regional level was not that all of these problems necessarily could be solved, but that by bringing together different leaders, we could start to work around identifying where there are commonalities and enough commonalities such that, for instance, if multiple lines of business and multiple health plans could agree on maybe 2 or 3 services that were relatively higher priority, that met more of their member needs, that maybe those 2 or 3 could be prioritized with the expectation that if that's in Ohio, for instance, that might look really different, or those services might look quite different from in Florida or Arizona or wherever it might be. That doesn't fully account for the challenges you're describing. I wonder if you think that a regional approach and multiple regional approaches can start to work through some of these types of issues.
No, absolutely. I don't see those challenges as reasons not to pursue the concept that you've talked through. I think I see them more as design considerations. So also, even as those regional models take shape, I do think some level of collaboration between those regional models that might also bring standardization. So for instance, in the national program that I had talked about earlier in the segment, we aligned around measures, payment model, et cetera, nationally. And so I do think, to your point, it might seem like, an elephant and let's take a bite of an elephant. But I also think that within those regional models, there's possibly a thread that leads to a national position, particularly at a product line level, that also might, bring some synergies to this work, an elevation of this work, not just at individual regional levels.
Jason, what's your take on all this?
Yeah, so listening to the conversation, it just takes me back to kind of what we heard from the pharmacies. And Angel, I think it's awesome that Centene is out in the field, like, in pharmacies, actually hearing their pain, right? Because a lot of times, pharmacists, I've had this in my career, you can get a little bit of imposter syndrome, especially if you haven't done a service recently. And so that's something that we heard from the pharmacist, right? Is like, okay, we need to know what services will get paid for, because if we're going to invest in technology, redesign workflows, and start documenting clinical care, there has to be a reason for us to do that, aka they know that they could, have a reliable way of obtaining reimbursement that makes sense for them for that. And so I think it really gets back to that, right? And so in the regional level, it's going to include, maybe a few health plans those pharmacists are familiar with, and then they can feel like they can take that step forward to invest in that technology. They can train their staff so they feel confident if let's say they started with like test to treat, and then they expanded out from there. And I think it's really, getting those pharmacists to understand that there is a consortium of the payer groups that they interact with, even if there are different lines of that, right? That they know that they can reliably make an investment and then, be able to show the benefit to the patient, the pharmacy, and to the payer as kind of a win-win-win.
Yeah, those are some really good points, and that was a great discussion. But let's push on a little bit. To close care gaps effectively in a pharmacy setting, data cannot live in a silo. A pharmacist needs access to clinical insights to make informed decisions. How should the industry approach data interoperability between electronic health records and pharmacy management systems to make real-time clinical intervention possible? Angel, I'd love to start with you on this one.
Sure. So first and foremost, completely agree that pharmacists need access to timely, actionable clinical information if we're really serious about closing care gaps and delivering services at scale. Really, for a pharmacist to intervene effectively, they do need enough context, right, to understand what's happening with the member beyond what they see just in a dispensing system. And so I do think this is a challenge we need to overcome. Many also have to be able to provide these services amongst many other tasks within their operating model. And so I want to make sure as we embark upon this work collectively in the industry that we are providing the right amount of information, because I can tell you it can get overwhelming very fast. So since time's not endless, we also can't provide endless data. We need to make sure it's not overwhelming. So I think that said, I think the industry, also frames interoperability as all or nothing. I think you guys might have talked about this in the paper as well. And so in reality, while we march towards maybe perfect interoperability, I want to make sure that I'm pretty clear that that shouldn't stop us from making progress in some of these other areas. And we have, other relationships within the industry that help standardize some of this data today for our pharmacists, and then provide them with the information. And then we continue to iterate on how we provide more based on the services that we're trying to provide. So certainly don't want it to be a gatekeeper for pharmacists and health plans partnering today. And so we'll continue to power through that. I do think we're doing that by building some of the direct relationships with some industry leading vendors that do help streamline that data for us. We provide it to them, they streamline it to the pharmacies. And in some instances, they're figuring out how to get that information into their workflow. Separately, and we've been a member of the pharmacy HIP for quite a while, I do think that there's a lot of information, or there's a lot going on in that space that I think can continue to march us towards maybe a more ideal state of interoperability, either in leveraging those industry partners or through other, direct mechanisms for more timely data. And so I would encourage us to continue to do that. I think right now we're definitely in a space where figuring out to have this information more in that pharmacy workflow will also lead to more efficiency for the pharmacy, and being able to provide these services, but also with the right information. So we end up with the right outcome too. We want to make sure that we're not asking pharmacists to do something and then the outcome's not matching the effort because they're absent key pieces of data.
Jason, you've spent a lot of your career working in this realm of sort of getting clinical information to the pharmacist, and you're also part of the Sequoia effort where it's talked about a lot. What's your thoughts on this?
Yeah, I would echo a lot of what Angel just said. I mean, I think when you think about this, there's a concept that's coming up of now, like the pharmacy EHR, right? Normally, we think about pharmacy processing systems as being called like pharmacy management software or systems. And really, that's excellent at using standards to get claims adjudicated, right, and process medications. However, I don't think the goal of this should be to dump the entire EHR into the pharmacy. The goal is to give the pharmacist the minimum set of actionable information that they actually need to make a better decision or, carry out the clinical service that they're trying to carry out. We all know there's all kinds of information in the prescriber side EHR. I think we need to clearly delineate, kind of what a pharmacy needs. And then I would also say too that, we shouldn't think about pharmacy interoperability as, just getting more information to the pharmacist. We should think about this bidirectionally. Some of the information that the pharmacist gathers and generates when they're seeing these patients could be very significant clinical information for the provider too. So I think that having a bidirectional coming from the pharmacy to the provider and then vice versa is an important nuance to make sure we capture.
Angel, to that point, does Centene, do bidirectional?
Yeah, I would say bidirectional in some aspects. I wouldn't say we're to the form of interoperability like we're talking about today. So what I would say, and I echo what Jason said about the bidirectional feeds and value that what the pharmacists are doing back to us is important. So we do require some information back. I would say that is occurring today. Through, flat file transfers, et cetera. And so we're certainly leveraging those to get that information. And in some aspects, we've even done some programs around getting social determinants of health back from pharmacies. And so I think that there's certainly opportunity, but today we do not have those pipes set up, but certainly see the value in that bidirectional feed as we continue to work through interoperability broadly.
That's a great comment. Let's move forward a little bit. So looking ahead 5 years, how do you see the pharmacist role evolving? And what one change would unlock the profession's potential? In this case, let's start with Seth. We haven't heard from you for a while.
I'm a data-driven optimist, and I think the future of pharmacy and 5 years from now is going to look quite different from how it looks today in a really positive way. The reality is everything looks impossible until the moment it isn't. And I think we're getting close to that point with scaling pharmacist-delivered clinical services. I think there's an enormous groundswell of momentum in the private sector from organizations like Centene, from national community chain pharmacies, as well as independents and organizations that work on behalf of regionals and independents. We're also seeing state governments take action and, as Angel mentioned earlier, allow for provider status recognition of pharmacists, scope of practice expansion, et cetera. Of course, there's still the challenge at a federal level that Medicare, as a result of the Social Security Act, does not recognize pharmacists as providers, and therefore Medicare can't reimburse pharmacists for clinical services yet. But there's also a lot of innovation happening. There's the Access program, in which the government, through the CMMI program, is providing direct reimbursement for digital health companies to provide chronic care services to members. There's the Rural Health Transformation Fund. And so I think we're getting to a point, and we talked earlier, Tony, you raised this issue of the cold start problem. Well, in the cold start problem, it can feel like a very Sisyphean task to stand up networks where there are networks of pharmacies and health plans, and they're trying to figure out how to work together and scale. And that can feel like a very Sisyphean task until you start to hit a critical mass. I think that I'm not going to argue that we're there yet. I don't think we are, but I think a lot of the infrastructure is starting to come together. A lot of the policy side is starting to come together, reimbursement, and we're getting there. So I'm optimistic, and love to hear from maybe Angel or Jason as well.
Angel,
Fully aligned to what you just stated there, Seth. Really, my hope in 5 years is that we see pharmacists become much more integrated and visible part of the frontline healthcare delivery system. And when I say visible, I think about how visible and how much pharmacists were talked about during the COVID-19 pandemic. And so I do think that there was that wave, and hopefully we're continuing to ride that wave a bit and kind of bring that level of visibility. We're seeing the profession evolve beyond just traditional dispensing, and that's the avenue that I would want us to go. And I think that there's lots of opportunity and momentum there. Especially because we're the most accessible healthcare professional in the community, and we interact with patients a lot more, as I mentioned earlier. Would definitely say I hope we're sitting here and everyone's thinking about pharmacists really beyond that dispensing role in 5 years. And I think we've been making incremental improvement there. And I think there's legislation, to your point, Seth, et cetera, that are, ideally going to make that a reality.
Jason, you're a pharmacist. What's your take on this? What one change would unlock the profession's potential, and how do you see the role evolving?
Yeah, so I mean, I think if we're talking 5 years out, that's so far in the future, given the changes with AI and whatnot. But just when I look at it today, demographics, right, are going to be the thing that I think push pharmacists into the forefront, with the aging population, the lack of primary care providers, not the lack of, but just the overall level of primary care providers that are already at a deficit compared to the population. I think that you're going to see states move first. And I do think, like Seth mentioned with the rural health transformation, the federal government is trying to, push some of this stuff down to the states. We are seeing regulations in states open up pharmacists for more prescribing authorities as well, which is going to lead to them ultimately providing more clinical services, I believe. And so I think also with AI, that will bring in more of these businesses that are running these pharmacies, that will make the pharmacy more efficient so it can free up the pharmacists to do more of these top of license practices. And, I think that will overall make the healthcare system better. I think that the interoperability will get there. We do have the e-care plan within CPDP, where this data can be shared back and forth, kind of like what we were talking about a little bit earlier. And I think that that's going to only grow, and then hopefully get us to that place where pharmacists and providers are sharing information together. And then there also, not to leave out that the payers will be driving a lot of this too. And so that's where I think we end up in 5 years is many of these regional efforts, I think, will grow into more national policy and national kind of standard interoperability of healthcare for pharmacists.
Well said, all of you. Angel, before we wrap up, we have one final question that we ask every guest who joins us on the Dish on Health IT. It's our chance to leave listeners with one practical takeaway that they can put into action. If you could challenge our listeners to change or revisit just one habit or perception starting tomorrow, whether they're a provider, a payer, a practitioner, a pharmacist who is a provider, what would that one call to action be?
Yeah, so we certainly talk about pharmacists being medication experts. And so I think that the one perception I challenge to that, though, is that we aren't just medication experts. They're really access experts. And so when we think about our healthcare system struggling with provider shortages, rising complexities, barriers to care, challenges health plans have with, moving quality measurements to the next level, I think we really should be asking and challenging ourselves how to better leverage one of the most accessible healthcare professionals that exists in nearly every community, including those rural areas. And so really my challenge is to not think about what pharmacists dispense, but more about thinking about what they can prevent or help solve.
Well said. Thank you. Angel, thank you for joining us today and for sharing your perspectives. It's been a great conversation, and I appreciate you giving our listeners a look at how Centene is thinking about the future of pharmacist-delivered clinical services and what it'll take to scale them. Seth, Jason, thanks for helping us connect today's discussion back to the broader industry research and the conversation that informed the white paper. And thank you to everyone listening. We hope that you found today's discussion to be insightful. You can find the Dish on Health IT wherever you get your podcasts, including Apple Podcasts, Spotify, YouTube, and other major podcast platforms. Be sure to subscribe so you never miss an episode. And if you enjoyed today's conversation, we'd appreciate it if you'd share it with a colleague or leave us a review. So until next time, Health IT is a dish best served hot.
Is it a challenge to stay on top of evolving interoperability regulations and the rapid pace of activity across the HL7 Fire accelerators? Learn more about POCP's Interoperability Outlook subscription service by visiting POCP.com, selecting Regulatory Resource Center, and then choosing Interoperability Outlook.